Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello, my name is James Latronica. I'm an assistant professor of psychiatry and of family medicine at the University of Pittsburgh School of Medicine. I'm also the young physician in practice for the Pennsylvania Osteopathic Medical Association. And today I was asked to discuss the concept of recovery because it is National Recovery Month. When I talk about substance use in general, I usually have a few sort of base concepts that I like to start with, whether it's talking about substance use or recovery. The first is that substance use is not the same as hazardous use, which is also not the same as a substance use disorder. In other words, just because someone uses a substance or clinically a substance appears in body fluid toxicology does not mean that they have a use disorder associated with that substance. Depending on what it is and what the clinical situation is, yes, you may need to investigate it. It may warrant follow-up. But as an example, there are way more people that use alcohol than have alcohol use disorder. And this is likely the case for essentially every substance. Many people use opioids without ever seeing me in my office. My role is I'm a family medicine physician, also addiction medicine trained. So that is what I do. All of my patients are a mix of behavioral health and substance use disorders. And so I see plenty of body fluid toxicologies that have various substances in them. And finding out why people are using and what their goals are is the foundation of a therapeutic relationship in the office, as well as figuring out what recovery means to someone. To that end, I will start with the American Society of Addiction Medicine's definition of recovery, which they suggest is a process of sustained action that addresses the biological, psychological, social, and spiritual disturbances inherent in addiction. I think that's a relatively reasonable definition. What I would say is both ASAM and other groups have considered getting away from defining recovery entirely. There's an idea within the field and without that over-medicalizing addiction, given the myriad inputs that go into developing addiction and treating it, that we should maybe steer clear of making things too clinical or projecting onto patients what their substance use goals should be or what successful treatment looks like. Because while addiction is a chronic treatable medical disease with a neurobiological origin, certainly in terms of the clinical diagnoses that we treat, addiction, substance use disorders are unique in terms of historical policy, a significant amount of stigma, and an inextricable relationship with the criminal legal system. So I think it's reasonable to ask, if we're going to describe recovery, is it worth having a broad definition when a lot of us, even clinically, aren't great at identifying what a substance use disorder is compared to substance use? So I think a reasonable definition, but talking about recovery in general, what we can do. So I talk a little bit about things we can do to facilitate recovery, and we'll use this broad definition for convenience for now. Some recovery myths. And then I do also want to touch on the overdose/poisoning crisis, because that is linked to addiction, but they are two separate entities. So using this broad term of biological, psychological, social, and spiritual wellness, in other words, getting people back to what they were doing to their life and not just surviving, but also thriving. The first aspect is support. People who have robust social support tend to do better. In that regard, one thing that we can collectively do is decide that we will no longer watch shows like Intervention, which are not evidence-based. They're extremely stigmatizing and are not just ineffective, but can actually be harmful. The idea of confronting someone and forcing them into a certain modality of treatment is counter to the field of addiction, both philosophically and in terms of the evidence base. So when we are watching mass media, whether it's news programs or television shows or movies, keeping in mind how substance use is portrayed or how recovery is meant to look, I think is an important start to broader destigmatization. Going along with that is the fact that how people view recovery, how people view treatment. If someone has an issue with alcohol, I think a lot of people's minds, especially lay people, goes to 90 days, somewhere warm, doing watercolors, not using substances, then going back home. But especially as osteopathic physicians, especially if you're in primary care, destigmatization and sort of quote unquote normalizing the treatment of addiction can allow people to get treatment faster and at a more appropriate level. A lot of people who have mild or moderate use disorders can be treated in the outpatient setting. Now, especially for my family medicine colleagues, but all primary care doctors, I understand there's this constant push to heap more onto your plates. And I understand that this patient population is unique for many reasons. So I'm not saying that anyone is a bad doctor, not doing their job by not treating addiction in their office, not at all. Believe me, I get it. What I mean to say is if you have that relationship with a patient, like we hope all osteopathic physicians do, primary care or not, you have a unique opportunity to help people in a way that will increase their level of trust in you and likely increase their odds of success, because taking the FDA-approved medications and keeping up with the other aspects of recovery, like therapy and peer support groups, is critical for sustained recovery. And there's not a ton of evidence on this one. If you ask the average person, would you go to your doctor if you had a problem with alcohol? I don't think they would say yes. And so that, I think, is a paradigm that needs to change. It'll take more than this podcast or a public health campaign. It'll probably take a lot of time, maybe even a generation. But especially when it comes to alcohol, which is much more prevalent, alcohol use disorder is much more prevalent than opioid use disorder. We can prevent a lot of illness and suffering and death if we catch folks who are using alcohol hazardously or have a use disorder early. So facilitating recovery to that end is finding a way to get people into the process of treatment and broad destigmatization and improved linkage with the healthcare system in general, especially with individuals they're already familiar with, I think is a critical goal, one that is so broad that it defies explanation in a format like this. But we have to decide as not just clinicians, but as a society, are we going to pay lip service to the idea of addiction as a chronic medical disease and not really get people the robust help they need? Or are we actually going to significantly shift some paradigms, both in terms of stigma and philosophy, as well as funding? There's one recovery myth that I like to talk about because it's one that can cause people to become frustrated and maybe fall out of treatment. There is this idea, and it's prevalent, especially in groups like AA, Alcoholics Anonymous, that once someone has what we call alcohol use disorder or a problem with alcohol, that person is essentially constitutionally incapable of ever using alcohol again. There is good evidence for this. That's not the case. Now, some people who have a use disorder, especially if it's something with incredibly high potency and lethality, like fentanyl in terms of opioid use disorder, there may be a reason to urge limited use or non-use in the presence of certain medications. But when you're talking about something that's so societally prevalent like alcohol, returning to use, which is the destigmatizing term we try to use for relapse, is not uncommon. And it's not necessarily a sign of failure, depending on the length, the other things that go along with that return to use. And so what I tell people is, if you're coming to see me and telling me about how you're doing with alcohol, what I call recovery and what you call recovery can be completely different things. If you're coming to see me, if you're engaging in treatment, I think that's the most important thing. That means I can continue to help you. If people become distraught that they slip up and then they skip their appointment and they sort of spiral, I think that's the worst outcome, especially when you're talking about things like opioids, where the mortality rate is so high because the banned supply is so potent. So the myth that once someone has a problem with a substance, they can never, ever use it again, I think is an important one to understand clinically for us. Now, the counterpoint to that is you don't necessarily want to encourage a return to use or encourage moderate use and someone who has a moderate or severe use disorder, especially early on, because we know it takes about 12 to 18 months with or without medication for our brains, for those addiction circuits on functional MRI to readjust. So I'm not saying that you have to have this huge spiel with every patient that you have who has a use disorder, but I think it's useful to keep in the back of your head, even if this isn't the entirety of the patient population you see, because if you deal with this patient population at all, you will see return to use. And it can be really devastating because families who, for example, have seen shows like Intervention and have created ultimatums and things like that, it can be both personally devastating in terms of health as well as what some social outcomes might be. I think that's one myth that has so many factors feeding into it and leading from it. That's one I would keep in the back of your head in general and at the forefront of your mind when you're dealing with someone who has the use disorder or you suspect may have some hazardous use. The last thing I want to talk about is the conflation of the addiction crisis, which I think there is one, with the poisoning crisis. We've tried to get away from calling it an overdose because what is available, I don't know that there's a proper dose of it. The reason I say it's important, and this is specifically with regard to opioids, it's important to know this is that, like I said before, alcohol use disorder is a lot more prevalent than opioid use disorder. Morbidity and mortality and costs associated with alcohol use disorder are higher than with opioid use disorder. What we don't have to worry about with alcohol use disorder is a poisoned supply. When you have a banned drug supply, there is an incentive to either cut it so that less of the actual drug you're selling needs to be in that mixture, or replacing it completely with something more potent so that it's easier to smuggle and more profitable, which is what we see. If we had methadone clinics in every large city in the country and in the suburbs, and everyone in the United States who is a physician or allied healthcare practitioner prescribed buprenorphine, we would still see an enormous wave of preventable deaths every year because the banned drug supply is so potent. We can't treat people. I can't help people if they die before they come to see me. And that's what's happening. And we've lost over 1 million people in the past decade. Every one of those deaths was preventable. And if you do an honest root cause analysis, it is because the drug supply is banned and poisoned. There are people who use opioids, as I said, and do not necessarily have opioid use disorder. We don't really have great data on the rates of that, but this will continue. The overdose crisis will continue until we decide that there has to be a different way forward, because increasing treatment is absolutely critical to treat addiction. Increasing treatment, increasing the amount of people on methadone does decrease the overdose rate, especially on an individual level. Methadone and buprenorphine are both protective against overdose in slightly different ways, but on a mass scale, they're not. And the evidence of that is despite continued attention and funding and public awareness, we haven't even really plateaued yet in our ever increasing death toll per year. So when you're talking with patients or you're talking with people who work in policy or people who are legislators, if this is an issue that you feel comfortable talking about, I would encourage you to really think about what it is we talk about when we're talking about overdoses or poisonings, because certainly a lot of people who overdose have opioid use disorder, have addiction, but the rate at which they die, the immediacy with which they do it is completely different than any other substance that people have an associated use disorder with. And the historical corollary to that was the wave of methanol poisonings, blindings, or deaths during alcohol prohibition. So to wrap up, I would just say that my overarching point is that I think recovery as a concept is something we don't necessarily need to define. I think getting people back into harmonious equilibrium with their biological, psychological, social, and spiritual health, I think that's a fine goal writ large. But I think it's important to remember that each person, more than any other disease process, addiction really has so many factors that you have to dig into from so many different angles, often with the help of professionals in so many different areas, that it may be wise to consider as a medical field, not defining that or not over defining it philosophically. And practically, I don't know that us defining it really does much of anything anyway. We can also facilitate people's recovery process, however that is, by supporting them socially. We can avoid myths like complete abstinence, especially for alcohol, is critical or you're a failure. Using destigmatizing language when available or when possible. reflecting patients' preferred terminology when appropriate is also obviously okay. And especially when it comes to opioids, because the opioid poisoning crisis gets the most attention, keeping in mind the difference between addiction and overdose deaths, especially in this arena. Thank you for your time. Of course, if you have any further questions or have any concerns about what you've heard today or want more information or want more extrapolation, you can always reach me via the POMA offices, and I tend to respond pretty quickly. Thank you for listening. And I think this is my 5th one, so maybe I'm friend of the pod now. We'll have to see. All right. Everyone have a great week.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube, or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.